Welcome to Headcast, your go-to podcast for all things stroke-related. Here we chat about care, rehabilitation, life after stroke, and the amazing innovations shaping recovery. Whether you're a survivor, a carer, clinician, or just curious, Headcast is where real stories meet expert insights, all with a friendly, down-to-earth vibe. We'll dive into the challenges, celebrate the wins, and even enjoy the occasional off-topic chat to keep things light. So grab a coffee, settle in, and join us on this journey. This is Headcast, connecting hearts, minds, and stories in the world of stroke.
Hi, good afternoon. My name is Phil Woodford and I'm your host for the Headcast. I recorded this episode 19 on Friday the 10th of April. It's now the 13th of April as I decided this weekend I was going to have a bit of time off. So I've slowed down on some episodes lately. I've had a bit of a bad flare-up of my arthritis, and what happened was the medication I get for the inflammatory bowel disease changed, and it meant I couldn't take the arthritic medication, and so they took me off the arthritic medication, and then I've had this gap where the other medication hasn't kicked in, and so now, and it's just ended up with this huge flare-up. I hadn't really been managed, I don't think, well enough in between, so I've now got some steroids, so fantastic. And I also had an operation, so I've had to lay back a little bit on doing some things. I had what's called a neuromodulation implant. It's not a pretty picture to think of this. Put into my back, and if technology works, I'll put a little picture up here so you can see. And with some wires down into my bum. And what it does, it sends an electrical signal to the sacral nerves, which somehow stimulates the message back up to the brain to say Phil needs a wee and to empty his bladder, as that wasn't happening. And I've got to say, it was a trial period for 2 weeks, but it worked excellent from the first day. Everything was like clockwork. It was like going back 20 or 30 years in terms of being able to go to the toilet properly, go for walks with the dog and not have to worry about I've got to rush home to get to the loo. So that was great. And I had some unexpected positive benefits for the IBD as well in terms of toilet, which you don't have to picture. So that's what's been happening there. So I'm now on the list to have that implanted permanently. And that's going to be about August, September this year. And fatigue's awful at the moment. I've been on SSRIs, antidepressants since the stroke in 2016. And over the last year, I've been weaning off those with the doctor. And so I'm completely off now, but I've got to say, it's really difficult. So much for not being addictive, certainly all symptoms. So tiredness and low mood, certainly one. So it's not, from what I've read, takes you back to where you were. It's the impact of the chemicals changing in your brain. So it's been a difficult time up and down. And I think getting out's the best thing for me, getting in the garden, getting out walking with the dog, trying to ride my bike. And today I'm going to be talking to Dr. Paul Balarji, who you're going to hear from. It's quite a long one today. And he's going to be talking about virtual reality and therapy and rehabilitation for stroke survivors. And Paul's also involved in developing stroke care in Africa through a charity, which he's part of. He may have even founded it. I'm not 100% sure. I forgot to ask that. But I found that quite enlightening listening to some of that. And, particularly Nigeria, forget how many people live in Nigeria, but, it's 1,000 per 100,000 people, the stroke prevalence. It's really quite high, and I think it's about 240, 250 million, the population. You can compare that to about 70 million in the UK and somewhere around, 50 per 100,000 with 140,000 strokes a year. So it's quite significant for them, the burden of existing cases. And there is no, we talk about trying to get 24-hour thrombectomy. They don't have it, other than for the uber rich in some private places. So it's really difficult. And you'll hear there's many reasons, but certainly across Africa and Nigeria, you'll hear about hypertension. It's, it affects nearly 1 in 3 adults in Nigeria. It's often undiagnosed or poorly managed. Obesity. So a lot of similarities to here, but possibly in a different order and on a different scale. Quite unhealthy diets and, like the rest of the world, sedentary lifestyles. Sat here talking into a microphone. Still quite high rates of smoking and alcohol use. And there's economic hardship. Again, like a lot of parts of the world, but that limits access to medications and healthcare services. And then you've got, on top of that, for different districts, cultural beliefs, myths and religious barriers that delay early treatment, increasing the risk of severe outcomes for people. There's a lot to do, but I'm quite sure that Paul and his colleagues have got a plan and they're going to get there. So I found it interesting listening to that. But I think you'll find the VR because it's something which is relatively low cost and again not difficult to access in the UK. And we'll talk within there about the guidelines for stroke and what should happen for people in this country who require therapy. And just to remind people what the guidelines say for this country, which is so when they're commissioning services in each area of the country, your health boards, these are they do it to these guidelines, and this is what's meant to be provided to the local population if they have a stroke. It says people with motor recovery goals undergoing rehabilitation after a stroke should receive a minimum of 3 hours of disciplinary therapy a day, and that's delivered or supervised by a therapist or rehabilitation assistant focused on exercise to retraining and or functional practice, and that's at least 5 days out of 7 to enable the range of required interventions to be delivered at an effective level, an effective dose, they call it. And it can be paced throughout the day, the therapy. It doesn't all have to happen at once, right? We're going to give you these 3 hours now. Let's just fatigue the hell out of this patient. It should take place staggered throughout the day. And as I said, the guideline says it can be delivered by a clinician. It can be delivered by an assistant. It doesn't say it can't be delivered by technology. There's a lot of different ways of doing this. And not everyone can tolerate 3 hours of therapy a day. It's, they've got other comorbidities, other conditions, so it's just too difficult. And I think where you'll hear today is the VR, because the research which they've done, with Paul's led, it showed it's safe. It's not going to cause people harm. It's not invasive. And for those that can use the equipment, it's it really helps cognitively. You'll hear about the impact it can have, how many more times than not having it. It can improve people's chances of a more successful outcome. So hopefully that will help. If you do want to read the guidelines, it's not bedtime reading, but you can go to a website called www.strokeguideline.org, and in there you can find it in all different formats and have a look through, and you'll see that's what's meant to be provided in this country. It doesn't always, not because people don't want to. It takes a lot of people, 3 hours of therapy a day. And those people aren't going to just be sat there on the stroke ward, I'd imagine. They're going to be dotted around hospitals doing lots of different things, getting called down for emergencies. And then they'll be on the ward. And some patients just require more input than others. It doesn't mean you can't deliver more than 3 hours. And like I say, 3 hours might not be applicable for some people. It might need a lot less because of their motor or functional ability. And they need some time. They've got to build up to it. But people undergoing rehabilitation, the aim is that they should be supported to remain active for up to 6 hours a day. The guidelines say that includes therapist delivers therapy, for example, through the use of open gyms, self-practice. You can see now where VR could come into that, carer-assisted practice, and engaging in activities in daily living and promoting cardiovascular fitness. When I was in the hospital and having my therapy in the rehab unit, I had electrical assistance pedals brought into the room I was in, so that at least if I sat there in a chair, my muscles aren't just going to waste away. I can pedal away. That's a £30 or £40 device. It's not an expense. We're not talking having to spend millions to do these things. Must have been 10 or 15 years ago at the last trust I was at, Hospital Trust. People undergoing dialysis, they'd be sat on a bed or a chair for hours, or they had pedals put on top of the bed so they could. I'm doing the pedal motion if you're watching this. I don't know why I'm doing it. You know what pedal in motion is, and they're doing the pedal in motion. We're pedaling on their bed with their legs, keep their circulation going. So there's lots of things that can happen that aren't just about what you'd picture stood at some parallel bars with a harness on, that you'd see in a film, trying to get yourself along. And I think VR has a fantastic place to play. It's been here for some while now. People have dabbled with it, but I don't think the evidence has really been there, or someone's done the work with the evidence to bring it all together and say, look, this works, and it's worth investing in. We're not talking to millions of pounds. It doesn't go off sick, VR. I'm sure it breaks down like any other bit of technology, but in the main, it's a reliable and proven bit of equipment. So that's the end of my waffle. I'm going to hand over to Paul now. As I say, it's quite a long one, but remember, follow, comment, and subscribe. It's all appreciated. Cheers. Right, thank you very much. Well, I'm joined today by Paul Balardi. Now, Paul, I'm not going to read out all your qualifications because we'll be here forever. But suffice to say, the headlines for Paul are he's a consultant stroke physician and education lead. But more than that, he's an award-winning healthcare leader, which means he's extremely stressed and busy. And so thank you, Paul, for sparing the time today, because it doesn't get any quieter for you, does it? So although it's 3 or 4 years out for me now from being in the health service, when I'm speaking to people, I'm speaking to colleagues who are clinicians, it just seems never ending. It's constant. It always has been, I think, but it just feels more acute at the moment. And I don't know if that's what's going on in the world. There's a lot people have on their mind. They're looking at apps, they're watching the news. That's quite pressured. Then they're coming into work and the patient list doesn't get any shorter. There's a waiting list probably for the waiting list, as it moves. And today, Paul, I was hoping we could talk a little bit about you, because I've followed your posts, certainly on LinkedIn, and some of the articles you've written. And it's really been eye-opening around some areas. So I was hoping we could talk about one or two of those. But first of all, I thought you could introduce yourself, Paul. You did a much better job than me.
No, I don't think so. So thank you so much, Phil, for inviting me. It's a great pleasure. I've read your story and I'm really inspired by the adversity you've overcome. And
Thank you.
So I'm a stroke consultant based in the UK and for the last 7 years. And before I moved to the UK, I did my residency program in neurology, then came to the UK to further my training in rehabilitation and then stroke medicine. So I'm a stroke consultant who is interested in all aspects of stroke medicine, from pre-hospital care to acute stroke care to stroke rehabilitation. So, and for me, I don't think stroke job is more of a life calling. It's much more than just economy. It's a passion, and I think it's something that I feel a lot of fulfillment. And the reason why I say that is that when I was younger, I did have severe stuttering. I had speech impediment, and my dad also had polio, so had some hemiparesis. So I was really inspired by my personal impediment and also by experiences from my dad. And I have deep empathy for people with neurological disabilities. And that was one of the driving passions for me to do stroke. And I'm so grateful I've been able to get to where I am. I'm doing what I love.
That's fantastic, Paul. And that can't have been a small feat, but genuinely, I'm under about 5 or 6 different specialities for different medical conditions. The people are all brilliant, but I've got to say, stroke sticks out like a sore thumb, in terms of the warmness of people. And I really do think the clinicians get it in terms of the life change, not just for the survivor. I often say I think the impact was bigger for my family than it was for me. I live with the impact constantly, and a lot of stroke survivors will say the same. I have to really think constantly as I'm talking to you now, is this left hand going to drop and knock all the controls next to me? And it's a constant battle thinking. But as I say, my family seem to have spent the last 10 years cleaning up behind me or carrying things, and I do think it's probably been a bigger impact for them. But I do think the clinicians really get that and get the impact when I speak to them, and it's just such a warm and welcoming community. But yeah, your lived experience, through polio, and it's because it's not something we hear anymore in this country. Not since probably the 60s do we hear a conversation around polio. So knowing a little bit about that from what I've read, that must have been a huge challenge for your father. And thanks for sharing about the stuttering. That's no mean feat.
Yes.
Paul, one of the things which drew me to you, I was reading, was about VR, virtual reality and rehabilitation. And with a world full of AI at the moment, it was nice to see something different around it. So what I was going to ask, could you just summarise what you'd read, what the research was saying around how virtual reality could help people in rehabilitation from a stroke?
Yes. And so we did a systematic review on the effectiveness and safety of virtual reality for cognitive rehabilitation for brain injury. We've had, I think in the last few years, there's been recent research on that. So our question was, how effective is virtual reality for cognitive rehabilitation after acquired brain injury, which includes, and is it safe? So we went through quite a rigorous review of literature, where we found about around 33 studies on that. And we analyzed them, and we actually found out that virtual reality, compared to standard as a therapy, was 4 times likely to improve the thinking, the memory, and even the general cognition of people
Wow.
after brain injury. And for us, I think this is very important also because we took all the studies, all the current studies on that, and there is benefits of that. And I do think it is important for VR to be included in routine therapy after stroke or any brain injury based on the evidence.
Fabulous. One of the challenges, Paul, that certainly acute hospitals face and the therapists is as part of the guidelines, the 45 minutes bit around therapy every day. And it sounds like a reasonable request, but the reality is there probably isn't enough people across the country to deliver 45 minutes of speech, OT, physical therapy, and dare I say it, psychological therapy every day for survivors. So this for me at the time just sort of was a bit of a light bulb because this could be self-guided as well, I take it.
Yes, indeed.
Because the guidelines doesn't say is how everything's got to be delivered, just that it needs to be delivered.
Yes.
So it's something which a patient could do maybe in a rehab centre or at home as part of continual development.
Exactly. I agree with you. I agree with you, Phil. And I think, yes, and I agree with you. We have few therapists, have very few staff in NHS. And 45 minutes sometimes might not be reasonable. Even after the 45 minutes, a patient who is admitted to the hospital has a lot of time in the hospital. Just
Yeah.
imagine how virtual reality also comes in, especially when the conventional therapy is quite very boring. Just pen and paper. You do something for cognitive rehabilitation, they fill a questionnaire, you do a lot of very boring exercises. And for younger people, just imagine having the virtual reality, having a virtual set, being immersed, and just, in your mind, you're going shopping, you are interacting with something, that is actually discussing with you, "Oh, this is how to do." And I think those short, frequent, prolonged experiences would promote recovery. Somebody said that brain is like a muscle. If you use it continuously, you know, you get a bigger muscles. And if you use the brain continuously with VR, I'm sure your brain will be sharper. And I guess also that's why I feel your brain is extremely sharp. It uses a lot frequently.
See, Paul, what I'm actually hearing you say is I need to get my wife in a meet. The doctors just said it's okay for me to buy PlayStation 5 with VR. You see, I might be hearing a different thing. What I'm hoping you'll tell me is cycling's good for me as well, so I can buy another new bike. Need all the excuses I can get. So in terms of VR, Paul, for people that don't know, how would you describe what VR is, virtual reality?
Yeah, I think that's a very good question. Virtual reality, as we know, it's and and they are grouped into different, things. So some are not fully immersive, some are semi-immersive. So and from what I can say is just like you're simulating reality in a virtual environment. And I think
Right.
also people watching film, sometimes can have a little bit of that reality where you have maybe you go to watch a very brilliant thing and you're just immersed in that. So virtual reality is like simulating a level of reality in a virtual world. And there are different aspects.
That's absolutely fabulous. Paul, one of the things which I've seen you post about, but I didn't fully understand, so I've tried to read up on it, and I'm not sure I still fully understand, so I was hoping you could explain a bit more, was about your involvement in what Ubuntu 360 is.
Yes.
And I appreciate it's not about a software system
Yeah.
for the geeks out there. It's more than that. I know Ubuntu has a meaning, doesn't it?
Yes. Yeah. Ubuntu is a concept of shared humanity, actually. That is a concept of Ubuntu. You have, I am because, we are. And so it's from the Zulu language in South Africa.
Right.
And one of the reasons why we started this more like a charity organization and more like how Kelly call it a movement, is to look at people low and medium income countries, especially Africa, people with underserved host population, and how can we improve stroke care in those underserved host population? Even in the UK, there's still a lot of things that we need to improve in stroke care, but just let
There's
alone,
a lot of disparities.
yeah, a lot of disparity, but let alone places in Africa, places in the Caribbean. So to improve stroke care in those countries, especially Africa. So I started it with also a radiographer, and we are just I think we are in the very nascent phase, but our goal and our aim is to make sure that stroke care is improved in those countries.
Thinking about Africa as a continent, we're talking about absolute millions of people and dozens of countries. So if it was more Western, I'd say there's a trifecta of condition or underlying reasons for stroke. Smoking, alcohol, obesity. They all play into each other for diabetes and other comorbidities. What would be the reasons in Africa, across Africa? What's the reasons for stroke in those countries? Is it the same?
Well, it is similar.
Right.
But here, there's a whole lot of, aging population. There's a whole lot of aging population in Western, But in places like Nigeria, the life expectancy is like 50s, and yet people are having
Oh my
strokes.
goodness.
Yes. So in Africa, we do know that there's more blood pressure problems. Is a significant risk factors. More than 50% of people older than 25 years, we have high blood pressure. So more than half
Right.
people older than.
Yeah.
So high blood pressure, uncontrolled high blood pressure, diabetes is a risk factors. People talk about intake of high salt, also diets, but there are also some other unique risk factors.
Mortality in parts of Africa, such as Liberia, and I was aware of that. But when you raise some of those areas, certainly it's around some of the salt, say, content and high blood pressure.
Yes.
Is that anything to do with? And I'll try not, is there a high salt intake, or is it the influence of people looking to make money with, say, processed foods that are being more imported into the country?
And I think I will say it's a combination of both.
Yeah.
And I do think, obviously, there's a whole lot of processed food. Then also before this importation of food, a lot of people eat the traditional food, very good leafy vegetables, plants, what they eat. But now, a lot of diets, a lot of processed food also is contributing so much. But also, I think traditionally too, our food sometimes, have high salt intake. We love a lot of salt.
Mm.
Almost everything we do, we put a lot of stuff there. So which is
Yeah, we have to be realistic. Salt, sugar, and fat. Mix it all together. It probably tastes lovely. It's a chocolate bar, isn't it? What's not to like?
exactly.
And I do think of Africa. And I don't know if I think about it wrong. I've always thought of it as being a healthy continent in terms of food and diet wise. And then I then wonder about external influences, because we've got smoking and we know its impact on high blood pressure and sticky blood. I'm sure there's a better technical term in sticky blood, but it's a term I heard recently, so it's stuck with me as a great descriptor. Ubuntu, what Ubuntu 360? And I get the aims of the organisation, but practical things, Paul, that it's doing. Can you give us some examples of those, please?
Okay. Yeah, I think the first thing is the first project we're trying to do is to build the first comprehensive stroke center in Nigeria. In terms
Wow.
of comprehensive stroke center, Nigerian government, a proposal for how we can, support with, establishing the first comprehensive stroke center. Obviously, this is a non-profit organization. Just what we're trying to do is to see how that can happen. So we had a presentation at some point in Abuja, which is the capital, with the Federal Ministry of Health, and we've had the proposals which has gone to the chief medical directors of all the also tertiary hospitals in Nigeria. So are the things we're trying to do. But it's not just Nigeria. One of the things we want to make sure that stroke care improves. And beyond just that is also we are developing something for stroke advocacy. We're looking at doing a project on how this BFAST also can be integrated into stroke advocacy, how we can translate them into local languages.
Right. I was just going to ask you, what's the awareness amongst, say, general population of the signs to look out for? And I think you've answered that. That's something that's ongoing, is it? And you're using BFAST around that?
Yes, it is ongoing indeed. Yeah. So I think that is a key thing, we're also trying to do. So just beyond just acute stroke services is also that hospital stroke care that we're trying to build. I mean, there's increasingly a lot of stroke advocates in Nigeria, but I think a lot of things needs to improve with regards to stroke awareness, the belief about stroke, and also the a lot of things, especially the ambulance also services, on how to get to the right place quickly. And even when you get to the right place quickly, how soon and how quick can they
Yes, because
detect this?
if you talk Nigeria, we're talking such a massive country, aren't we? And
Yes.
I don't know actually what the physical road network's like,
Yes.
to facilitate, rapid transfer.
Yeah.
And I'm sure you'll get to the point of having this centre, because in fairness, now I'll play it completely down now and do a disservice for it. But what we're talking about is bricks and mortar, aren't we? Where really what's going to deliver a centre is people.
Yes.
So in terms of establishing the centre, I can't help thinking it's policy that needs to drive it rather than bags of money on this.
Exactly. And I think there are centers that are equipped with you know, equipment. They have a cath lab, they have an angio suit, but there are a lot of policies, like you said, that needs to go into it, top bottom approach, the will to make sure that stroke is an emergency and people should be able to have treatment as soon as possible. Nobody would know when he or she would have a stroke. It's not like chronic disease that over time,
No.
it's unexpected emergency. And there should be a way where everybody with stroke can have access to some very good care.
I applaud you, Paul. I think it's absolutely fantastic what you're trying to achieve there.
Thank you.
And I'm quite, as I say, generally I'm confident that, yourself and your colleagues, you'll get to a point of there's some way where you can hang the badge on and say it's there. It is then going to be down to the will of the government, isn't it?
So, yeah.
But there is that famous African proverb, if I can remember it, about it takes a village.
Yes, indeed.
And I can't help thinking this is about community power, certainly when it comes to the community recognising that this isn't just grandma or grandpa that has the stroke. This is me and me in the street, and this is what we can practically do when we recognise it.
Mm.
And I do believe you'll get there.
Thanks.
I don't think it's the sleeping giant anymore as a continent. It's here, isn't it? It's so powerful.
Yeah, it is.
I really do want to succeed. And I guess I'm biased because I've had nothing but good dealings with, first of all, with Nigeria in the past and people from Nigeria. So I guess I am biased from that, wanting to see it succeed. But I'd say the same about anywhere on the continent. Everybody deserves the same. But we've seen it in our own country. We've got some patches of excellence. Not enough patches is the problem. Certainly when it comes down to comprehensive stroke centres. We certainly know we've got some shining lights, and then if you live in the wrong area, your light hasn't been turned on yet. But there's a lot of challenges and it's difficult. So it is down to the policy driving it and the will of the people as to how important they see it. And I don't suppose it's much different there, but it's taken a long time, I guess, is my point, to get to where we've got to. So whilst we're still not there, we're 11, 12 years since the Mr. Clean trial, saying this is the gold standard. This works. And actually you can now extend it up to 24 hours. Under the right circumstances. Crikey, we could be transferring people where I live to Paris. In that time to get the treatment. So we've just had the when it was only at the beginning of the year, we've had the groundbreaking robotic thrombectomy.
Yeah.
Delivered from Dundee to America.
Yeah.
And so maybe your dream of your comprehensive stroke centre, either in Lagos or Abuja, could be the stroke centre it could be the centre for the whole country, or it could actually be that it's in Southampton.
It's true.
And it's where you have the suites and the you don't need the interventional radiologist everywhere. Then you need someone to do the first cut.
Exactly. Telemedicine is here to stay, or robotics.
Yeah, it's phenomenal, isn't it? I wonder where all this technology's come from. Not a conspiracy theorist, because it'll keep you up too late. AI and the other technology, it just seems to have happened.
Yeah.
It doesn't seem to be a slow burn, does there? It's like electric cars. It's probably been 5 or 10 years. We've seen them get better and better. The range has improved.
Yes, indeed.
Bit of technology in them. They can hold their own. But we don't seem to have had that with some of the technology. It just seems to be. We've been talking about it, and now it's just here.
Yes, it is.
And robotic thrombectomy is an example that's been talked about probably for the last decade and trialled. But all of a sudden they've had this breakthrough, and I guess that'll help people with investments and policies. They'll go at speed now, and it is about money, and people will feel more confident to invest. And hopefully they see that with Nigeria and the rest of Africa. Actually, this is something to invest in, because we're investing in the people, not in the systems. Paul, your VR rehab work is phenomenal. 4 times cognitive possible improvements for people. It's not age restricted within reason. It's safe. It's relatively low cost. It's not what's not to like about it. And it's fabulous that you and your team been able to do that systematic review of the evidence out there, because it has been talked about for some while as a means, and I think mainly because some of the private industry's driven it because it sells things, it sells devices, but actually to bring all of that research together and say this is a standard you could deliver, and it fits in well with the guidelines, as you say, and the work you're doing with colleagues in Africa, it's to be commended.
Thank you so much.
It really does. Yeah.
So,
Paul, before we go, I noticed you've changed jobs, or you've got a new job.
yes. So, yeah,
Congratulations.
I've moved from Dorchester to Worcester. So I think,
Right.
yeah, so that's why, yeah. So I changed job, and it's more with regards to family, just to make sure,
Yeah.
Also it's what family wants.
So good luck with that.
Yeah, thank
I'm
you so
sure
much.
it'll work out fine.
Really,
And we'll speak again soon.
yes, thank you so much. And I just want to say once again that well done for all the things you're doing. And I think to me is you are inspiring. One of the research I want to do next is to write something about the 8 hours of neurological recovery. I'm just doing a bit of drafts of that. So I invented this 8 hour, which is a step ladder to neurological recovery. And one of the things is reinvention. One of the hours is reinvention for a new identity. I think it's very important that it's not just all about, it's all about somebody, speaking to the stroke survivor about having a renewed identity. Like you said, it's not all about going back to where you were before the stroke. It's all about reinventing that new identity about you and finding meaning and purpose.
I don't want to mess with your R's because I work in pictures and I can see it now as a little step, so it works really well in my mind. But
yeah,
I can't help thinking what you're talking about is acceptance. I remember I paid to see a psychologist probably about 2 years after having a stroke. And I remember, if they say the same thing, don't they, counselling psychologists? We can't tell you what to do. We'll help you work through it and ask you the questions and you'll come to it yourself. But she did stop. I won't give her names. I don't want to give her away, get into trouble or something. But she stopped it and said, look, I'm not meant to do this, Phil, but I'm going to tell you, you haven't bloody accepted anything. I said, what do you mean? It's obvious I've had a stroke. I'm sat here in a chair with wheels on. And I know I've had a stroke. And she goes, no, you're just making everything really difficult for yourself. She said, and I was telling her a story, but I'd had an argument with my eldest daughter, and it was about asking my daughter to get something from upstairs for me in the house we were living in. And that ended up with my daughter having a bit of a strop on, not wanting to do it. Dad, why can't you get it yourself? Well, I can't get up the stairs. And so I'm getting grumpier and grumpier. And the psychologist is saying, well, what is it you wanted? So I told her what I wanted. It was a book or something. She said, and was it that urgent? I said, no. She goes, you go upstairs every day? I said, yes. She goes, why aren't you wearing a bag where you can put the stuff that you want to bring down for yourself? She goes, why have you made it, this problem for your daughter? And I'm thinking, well, they'll take it her side. I'm paying for this. But she was right. I hadn't accepted, actually, this is a new way for my life now. I've got to work this a different way. I can't just rely on everybody to help me. Yeah. And it comes back to that invention, I guess. So for me, I guess I've been frustrated at the pace of change that I see. And a lot of what I see, I get frustrated because it's not particularly difficult or expensive. Some of the things which you experience as a patient, I just can't be doing with the bureaucracy you've got to jump through. And it's not just in the services I come across. So I guess I wanted to use my voice as much as possible, just to share some of those frustrations and support the charities that are trying to do good work around it, such as Different Strokes or the Stroke Association. Yeah. And there's many more out there. Yeah. So yeah, wherever I can lend my voice or experience.
You're the true hero.
I don't know. My plea to you, though, Paul, as a clinician, I'm sure you do it. One of the frustrations from my perspective, and I'm sure it's from other patients as well, is being asked for your experience when nothing being done with it. So I don't expect somebody suddenly to build a brand new unit because I had a particular experience. But if I tell you, actually, taking me for a wash bruises my legs because you jam me into the sink every day because I can't walk there, I do expect you to change the sink. And I guess it's some of the expectations. And so there's some frustration around that still with me when I'm asked for my lived experience, say go to a conference and can you share it? And I am often of the point, no, I can't, because I don't think you'll do anything with it. I spoke to it wasn't his responsibility to do it, the NHS England medical director and at a conference. And he said, no, share your story. There's hospitals here who will listen to it. Well, I shared the story, and it wasn't about their hospitals that were there. It could apply to anybody, but nothing changed. And it's just a real frustration.
Yeah.
So I collapsed in hospital in a shower. And I'm sharing this with you and anyone listening because I'm hoping people might do something with it.
Yes.
So I was in for a suspected TIA in Neuro Hospital, and I collapsed the following morning while having a shower before I was discharged. But the point of it was, that's no one's fault, but I was in the shower or I collapsed. That unfortunately is life, and that's when it decided to get blocked and over I went. But my point is, the cable to get help, because I'd lost my speech as well, so I couldn't cry out for help. I couldn't sit up to bang on the wall. The cable's in the corner of the room. Now, people don't collapse at the cable. We're just not that smart, are we? We collapse and go down.
Yes.
And I didn't know what the solution was for this until I was on holiday about a year after the stroke in Holland. And this will make sense. And I was in a toilet at a Holiday Inn hotel. And all around the bottom of the toilets, the accessible toilets, was the pull cord. And it was looped around the floor, around the edge. So if you fell, because people do tend to fall away from something. So if you were on the toilet and you fell off, your foot or your hand, you could grab the orange cable. So I took a photograph of this and I sent it to the estate department where I worked and just said, look, I'm sure you've got some standard that says, the orange cable's got to be 2 inches away from the toilet and it's got to fall at this angle. I know you'll have some bureaucracy, but actually it's not going to be illegal that you put a cable all the way around that joins to it. It's probably about £5. And a couple of little ring holes to put this cable around. Could we do it? And it did fall back into the it's too hard to do box. That's not what the standards say. We have our hospital regulations for building a hospital, and this is how it should be. And I never did get in touch with the hotel, and I should do, because I'm going back there this year, and I might go back to the hotel and just say, look, why did you do it this way? And I can't believe it's actually either they do it like that all out their country, or they've just experienced it. Somebody's collapsed in their toilets and we provide an orange cord in this hotel. But, how can people come to help if you can't pull the cord? So it's only a silly little example, but I've shared it at all the events I go to say, look, there's something you could do today which would cost less than a tenner. And it potentially going to save someone's life. It could be you, your mother, your father, your child. All you got to do is extend that cable around. So unless there's a real safety issue I've not thought of, and it'll probably it'll fall into the, what's the word they use? Ligature. Someone theoretically could lie down and put it round the neck. I get that. And so if that's the reason, that's the reason. But I've never had it fed back to me to say, you're trying to work it out for myself.
Really? I think that's it. Yeah.
So sorry, Paul, I go off on a tangent.
No. I think
I wanted to share with you. That's my plea before we go is if we're going to get patients' experience, then set their expectations and try and do something with it, or at least feedback why we're not going to. It really makes a difference to people just to know. Actually, I was listening to, and I understand why they can't. And if someone doesn't work in the hospital, they won't realise actually the ligature issue and the regulations and the inspections that check all of that for them. Actually, it's not so straightforward because we can't even put a hook on the wall just in case somebody uses that to harm themselves. Paul, thanks for today.
Pleasure, Phil. Thank you so much for being here.
You're welcome. Take care, Paul. Bye-bye.